Asthma in pregnancy. Let's we know something about it. Asthma is an episodic disease with acute exacerbation interspersed with symptom-free periods. There is three main symptoms: dyspnea, cough, and wheezing. Dyspnea is breathlessness due to bronchoconstrictions. It may be either due to allergy or due to genetic association. We can find these three symptoms, dyspnea, cough, wheezing, in so many other different conditions like pulmonary emboli, chronic bronchitis, foreign body aspiration, bronchial stenosis, carcinoid tumors, eosinophilic granuloma, and last but not the least, acute left ventricular failure. So, it should be differentially diagnosed, and its diagnosis must be confirmed by or through history and investigations. History thoroughly include personal history, family history, and treatment history. There are some tests to investigate it. Asthma is reversible airway obstruction. Reversibility is defined as a 15% or greater increase in FeV1, forced expiratory volume, after 2 puffs of a beta-adrenergic agonist. Next, showing heightened airway responsiveness to challenge with histamine, methacholine, scopine, induced hyperventilation. Third is positive fill and flare reactions to skin test can be demonstrated to various allergies, which is not necessarily even correlate with asthma. Next, sputum and blood eosinophilia and serum IgE level, which is also not specific. Next is chest X-ray showing hyperinflation. Asthma can be mild, moderate, or severe. Although asthma is considered primarily a disease of airways, virtually all aspects of pulmonary functions are compromised during very severe acute episodes of asthma. Severe obstruction persisting for days or weeks is called status asthmaticus. Besides this respiratory compromise, there is also metabolic acidosis and alkalosis, cardiac consequences, and nervous consequences. Especially cardiac consequences are right ventricular hypertension and pulmonary hypertension, cor pulmonale, and tachyarrhythmia. The course of the illness and effectiveness of the therapy can be followed by measuring PEFR, peak expiratory flow rates, at home and FeV1 in laboratory. Laboratory finding in symptomatic patients is FeV1 less than 30% of expected, vital capacity less than 50% of normal. In acutely ill patient, residual volume reached up to 400% of normal. Management of asthma either during antenatally or during labor. In acute and severe asthma, management should be started in these steps: oxygen inhalation with mask, beta-2 sympathomimetic, as example epinephrine, 0.3 to 0.5 ml in 1:1000 dilution, subcutaneously or IV 3 to 4 times at 20-minute interval. Then IV corticosteroid 200 mg stat and repeated after 4 hours. IV aminophylline 250 mg slowly. Terbutaline 250 microgram subcutaneously 3 times at 15-minute interval. Hydrocortisone 100 mg 6 hourly IM throughout the labor of patient on steroid before pregnancy. Opioid analgesic is contraindicated due to bronchoconstriction and respiratory depression. In pregnancy, prostaglandin is also contraindicated. Spinal anesthesia and epidural anesthesia preferred over general anesthesia because of risk of atelectasis and chest infection. Noticeable thing is, halothane is better for general anesthesia. One more thing about mother and baby in asthma is breastfeeding must be encouraged as it delays the onset of allergic problems in child. For subacute, mild and moderate asthma during pregnancy, treatment plan are salbutamol or terbutaline 2 to 3 puffs 4 to 6 hourly. Second is beclomethasone dipropionate 2 to 4 puffs 4 times daily. Third is disodium chromoglycate inhalation is used as prophylactic measure. Hopefully, these lines cover most of about asthma and its management during pregnancy.